Welcome, and thank you for being here. My name is Carin Mikos, and I am a registered nurse and end of life specialist. I am also the host of In the Gap, a collection of stories from folks who stand in and work in the gap between life and death. Great. Welcome, everybody, to In the Gap. I am your host, Carin Mikos, and my very special guest and friend today is Laura Balland. She is a palliative care doctor, and we've met a couple of years ago working in hospitals close to us here in Connecticut, doing some very important hospice work. So welcome, Laura. How are you today?
I'm doing so well. Thank you for having me.
Yeah, you're welcome. I think the first question I want to ask is, what is a palliative care doctor?
That's a great question. And I really am answering this question every day because it is still relatively a new field in the formal sense, but it's really been around ever since humans have been around. And basically how I describe palliative care and what a palliative care doctor does is it's just like any other medical specialty. It requires a bit of extra training beyond what my base training was for residency. And I focus on quality of life, is how I say it. So I see people who are dealing with very serious illness. Sometimes that illness is curable. Sometimes that illness is chronic for many years. And sometimes that illness, unfortunately, is terminal. And my job is to help people who are struggling with any symptoms from that illness try to get as good of symptom management as possible. I also add a lot of support to their families and to themselves as they're going through their journey. And the beauty of palliative care is it's not just me. I'm actually joined by a wonderful team, including nurses, social workers, and chaplains. And then last, definitely not least, would be I can really help people navigate what's going on and act as a sounding board for when tough decisions come up and which way they want to go, whatever is aligned with who they are as a person.
Could you share with us maybe a story or an experience that has stuck with you where you had some of those difficult conversations and the outcome?
I actually had one yesterday. It's a very unfortunate situation. It's a gentleman in his 60s who he's at the end of his life, and the family appropriately are very worried about his nutrition, as we all are. I think food and liquids are very important in terms of how we provide love and how we make sure that our loved ones' bodies are sustaining themselves. But this gentleman is at the point where any sort of artificial nutrition would actually be harmful. And so I sat down with the family. He was not able to participate in the conversation. And I had to very gently explain that although it may seem like he's going to quote unquote starve if we don't give him nutrition, the reality is that he's most likely not feeling any of that. And that the more we do try to do to him, the more harm we will cause. And we had a wonderful discussion about what it means to be at the end of life, what happens to the body, and that they can still give him pleasure by putting a little bit of chocolate in his mouth and making sure that his mouth is not dry. And I think they really, I hope they really got some peace from that conversation.
Yeah, I bet you could hear a pin drop in that room.
And lots of tears.
Yeah. When you say like actually giving him nutrition could actually cause more harm, what do you mean by that?
So we thought back in the day, we thought that we should be giving people nutrition either by mouth or by a tube in the nose or in the stomach, as well as IV fluids up until the day that they pass away. And I think that is a lot of it is entrenched again with how we as a society, as cultures, as human beings, how we view the basic necessity of nutrition. But people who have been involved in the care of the dying have seen actually that artificial nutrition, artificial hydration actually backfire. They cause a lot of issues. The fluids, for instance, that can accidentally go into places we don't mean them to go. So they can accidentally go into the skin. They might go into the lungs. They're not doing what we had hoped that they would do. And the same thing with nutrition. So we know now that as the body is dying, it just really can't utilize those resources anymore. It can't utilize the nutrition. It can't utilize the water. And we know now that it's actually better not to give artificial nutrition or hydration at the very end of life.
So I just want to digest what you just said. So at the end of life, the machinery that is the body, you're saying no longer requires nutrition or fluids, and in fact may actually be not so beneficial.
Yeah, in fact, will be harmful.
Yeah.
And that's actually the word I use, is harmful, is how I counsel the family members, is that at the end of life, we want to do everything we can to make this person comfortable. And if they are feeling thirst, absolutely, we can give them something by mouth. But in the very well-meaning attempt to give them IV fluids, we will actually end up doing harm. And it might not be right away, but it will end up happening because the body simply cannot process it anymore.
It's amazing how it's been, in my experience, how the human body and the sequence of which the body shuts down in those final moments or final weeks, even to moments, it's almost perfectly designed. And you're right, as we add fluids or nutrition, the body just cannot process it.
Yeah. And to your point, the perfectly designed, I think as hard as death is to wrap our brains around, to accept, to watch, it is one of the most natural processes that our bodies will ever go through. The same as being birthed. And so I think when we as humans, and still with the best of intentions, try to intervene in that process to slow it or to stop it, well, there's nothing that can ultimately stop the process of death.
Yeah. Yeah. And have you always felt this way about death and dying?
So it's really funny. I actually used to be on the opposite end, where I wanted to do everything I could to stop the process of death. So I don't know why exactly I felt that way. I have some memories when I was younger. So I had always wanted to go into medicine. I remember since the age of 6, I wanted to be a doctor. And growing up in the 90s, the show ER was one of the most famous shows on television. And I would watch it religiously every Thursday night. And I just loved the idea of being on this line between life and death, and a person being straddling this line, and me as the physician going in and pulling them back into the world of the living and preventing them from going into the world of dying. And so at first I thought I was going to be an emergency medicine doctor. I also really liked the idea of trauma surgery. Again, this helping people not cross that line into death and saving them. And then I had a really formative experience with my own family member. I was a pre-med student in college, and my grandmother, who I was very close to, she helped raise us. She lived with us for a while and was one of my best friends, really. And she had an unfortunate decline that many older adults do. She was 95 and had been living on her own, an incredibly independent woman. And unfortunately, just after a series of falls, was in a living facility. And I got a call from my mom one day while I was in college, and she told me that grandma was dying. And it was incredibly hard for me to understand. I had just seen her a couple of weeks before, and while she didn't look wonderful, she didn't look the healthy version of her that I remembered, and she was appealing frail, I certainly did not think that she was at an end of life situation. And so I got to her as fast as I could. And by the time I did, she was already in an inpatient hospice facility. And I really struggled with this idea. Again, I was perseverating on, we were starving her, we weren't giving antibiotics. How could we do this to her? And it was the most beautiful death that I could have wanted for her. Now, not just looking back, realizing this, in the moment, finally, when she did pass, I realized I was able to be with her. We were all at her bedside when she passed. We slept overnight with her. She was incredibly comfortable. And that was my first introduction to what hospice care and what palliative care can really do for people. And after that, I then volunteered at an inpatient hospice unit for 2 years. I couldn't do much. I was still a pre-med student, so I couldn't do much, but just being in that environment, watching how people cared for people who were dying. I once volunteered to do the 11th hour sitting at the bedside. That was it. My mind had been made up that I wanted to pursue palliative and hospice care. And so when I was applying to medical schools, I was very aware that Mount Sinai was one of the leading places for hospice and palliative care. And I was very fortunate to get into the medical school there. And so that solidified my track.
Wow. Amazing.
Sorry, that was long-winded, but
no, I felt like I was on a journey. It was great. It was really great. And I could see how this med student, so committed to making a difference in what was considered probably the positive way, the fixing, the treating, the curing. And then all of a sudden your whole world got flipped upside down. And it all came from the love of your grandmother. You could put aside your personal preferences to fix, treat, and cure, and actually just be with your grandmother in her final time and just love her up and love the family that she had created. I think that's a remarkable journey. I'm not sure that a palliative doctor could have been created any better way. That's amazing. That's just amazing. So there you are, working long hours in a really struggling healthcare system, having these difficult conversations day in, day out. How do you protect yourself? How do you fill your cup? How do you provide the best you that you can for these people that are in these places, these darker places?
So I really, truly think about my experience with my grandma almost every time I'm with another family, because it is so painful to watch some of these families already grieving, experiencing the anticipatory grief, the patients themselves who are awake and aware of what's happening, experiencing the grief of losing their life, about what's to happen. Sometimes watching that, the pain is too much that I sometimes think, I got to get out of this field. I can't do this. But then I am always drawn back to the hospice people who took care of me and my family, and how incredible it was what they did for us. And had they not been there, the way my grandma could have died could have been very different. She had essentially developed an infection of her gallbladder that spread very quickly and went into sepsis. So a huge inflammation of the body, and certainly would have led to death anyway. But we could have been doing many different things to her body. She could have been in an ICU. She could have been on a breathing machine. She could have had multiple lines in and out of her. Had we not had the care of people trained at the end of life, for end of life, that's very much what could have happened to her. And knowing that I can step in and provide that same kind of environment for people to just be with their loved ones, not go through those invasive measures, that really is what powers me. And I actually explained this to a family yesterday, because the same family that I spoke about earlier, the family who was struggling with the artificial nutrition, And they thanked me and they said, I don't know how you do this, which is a comment I do hear a lot.
Yeah.
And I just told them it's because somebody did it for me and my family at one point, and I decided I wanted to pay it forward.
You're giving me the chills. If you could see my arms, I got goosebumps. Like
Oh,
I can just, what you just said just really resonated with me and filled my heart a little bit.
thank you.
So thank you for sharing that. What do you do with your time off? Do you find that you're so close to death all the time? Do you find that during the time when you're not working, are you overly living? Do you find joy in the small things? Like, how does being a palliative care doctor, being so close and personally related to death and dying every day, does that affect your life when you're out there not doing that?
It does. I don't know if it affects so much of the day-to-day actions that I may be taking, but it really affects the day-to-day thoughts that I have. So I have seen some tragic cases, people in their 20s who get a terminal disease, people who had just retired and had all these dreams and get a terminal disease. And all of this grief and the realization that you cannot take life for granted, that has really helped shape how I think about things. So, for example, my husband, who's not in the medical field, but he and I talk a lot about how our philosophies on life are shaped by what we do. I've now become more of a seize the moment type of person. Before getting into this field, I would probably say I was more of a, we got to plan for the future, always be thinking about our retirement, got to do all these things and plan. And now that I realize that tomorrow's not guaranteed and my life could reach a terminal point at any stage, unbeknownst to me, I really want to be able to focus on the now, on the present, do things that maybe other people are waiting for. Take that trip to Thailand now and not wait until I can retire. That's how I would say that this job has really shaped me. In terms of the day-to-day of what I do, if I'm being really transparent, I watch a lot of TV. And I think that's because it's an escapism.
Yeah.
I'm able to escape into different worlds. I'm able to not think about death and dying. I can watch a wonderful comedy show that has nothing to do with death and dying. And so for that, I think, yes, there is a lot of living and trying to stay in the living that I do when I'm not at work.
Yeah, amazing. I would totally echo everything you said. Working in hospice, being close to death and dying. Daily, I call people and just tell them I love them for no reason.
I talk to my dad every day.
Yeah.
And we say we love each other every day at the end of the call, because you don't know when that last day might be.
Yeah. Yeah. My brother, he'll probably hate me for saying this, but he went through some stuff, some cancer stuff. And I totally credit that event to him and I increasing our communication and really being able to express our love to each other. He went through what he went through, and I had my own little medical emergency. So the two of us, a little mortality crept into our lives. And really from now, it's like a weekly occurrence. I just call him up and, hey, brother, I still think you're a jerk, but I love you. Like that kind of thing happens all the time. And I'm just more free, I think, with my expressions of love to people, even people I don't know. Laura, I love you.
I love you, Carin.
It's easier for me to say because I get how quickly things can change.
Absolutely.
Yeah. Is there a future in palliative care? Is palliative care moving in a direction? Like, is there new stuff coming?
So I think probably the biggest thing that I see the palliative care field really pushing for, and my colleagues may disagree, they may be much more wise than I am and see a different future, but we really talk a lot about primary palliative care. So when we say primary palliative care, what we mean is physicians, nurse practitioners, nurses, PAs who are not, they're not special, they're not, they didn't do specialty training in palliative care. They're not going to be seeing the very complicated cases, but they are on the ground every day seeing people who have palliative care needs. So who have symptoms that need to be palliated, that need to be controlled. They've got emotional needs that could really use a wonderful helping hand. We really want to try to get non-specialized palliative care providers to have these basic primary palliative care skills so that in the absence of a palliative care specialist, because we are not a very common field, a person dealing with serious illness could still get some of that care. And then when things get much harder, then our specialty can certainly come in. I think that is where a lot of the push is going to be.
Yeah, it sounds like a team.
Yes, and trying to make other providers more comfortable with death and dying. We have a saying in palliative care because I work a lot in a hospital and as a consultant. So my team, we're constantly getting consulted by another team. Half or maybe even more, the work that we do is really there to support the team. So what I mean is that there are many cases in the hospital, especially where clinicians who are caring for a patient, they're experiencing a lot of moral distress. They're watching a case that is end of life to us, and maybe the patient and the family, they don't see it that way. And the incongruency causes a lot of distress on the clinicians. And so we often get called in that moment. And we know that we're not just there for the patient and the family, we're actually there a lot for the team. And so I think of palliative care I think of palliative care as not just caring for the patient and the family, but doing a lot of education and support for other clinicians.
Yeah, totally agree. Even it's been my experience that even folks like oncologists are uncomfortable with an end of life conversation, which blows my mind a little bit. And I also totally get it, because who doesn't want to fix and treat and cure cancer?
It's great that you just brought that up. I'm also a geriatrician, and part of my job, not as much, I don't do geriatrics as much as I do palliative care, but part of my job does have me in an outpatient clinic taking care of community dwelling older adults who are they're more well, they're a bit healthier. I can tell in myself when I have my geriatrician hat on, I am constantly thinking, how am I going to save this person? How am I going to prolong this person's life? This person is looking to me to help them stay alive. And I have to constantly remind myself to utilize that palliative care part as well. And I also sometimes work as a hospitalist. So I will be in a hospital and I'll be the person that is the primary person taking care of a patient who's in the hospital. And when I have my hospitalist hat on, I can actually tell my brain switches off the palliative care and says, you got to keep this person alive. What do you do? What do you do? And it's a constant reminder of it's all together. You can utilize both. And I think more and more oncologists are starting to realize this. We in fellowship, because we have a fellowship where I work, we're having more and more people with oncology backgrounds join the fellowship to learn palliative care. I think they just didn't get that training in their fellowship before, and now it's becoming more and more recognized and more appreciated and more desired.
Yeah, it sounds to me, it's a return. It's a return to holistic caring of people. Like way back in the day, when your parents lived with you forever in the same home, we took care of them. As they aged in whatever that looked like, whatever they needed, we took care of them. And then when they became hospicey or bedbound, we took care of them. Like it was just, I don't know. I'm so excited to hear that physicians with all these specialties are also interested in getting palliative care. I feel like that's where the heart is.
Yes.
Because even if you are a hospitalist or a gerontologist, or people still need to be treated like people and not diseases or some prognosis or even a culture. They're people. And we as healthcare professionals need to provide what the people want for themselves. If they don't want any more treatment, we need to honor that.
Absolutely.
If the 98-year-old is more interested in just living his best life for whatever that looks like, instead of going to the doctors or spending all this time and energy back and forth, he should be allowed to.
And
very
well put.
I think it's great. I'm happy to hear that palliative medicine is growing, expanding, and it sounds like it's going in a decent direction too.
It is.
And you want out. You want to get out of it.
I think about this sometimes is, how long am I going to do palliative care for? How long can I stay in this field where I see death and dying every day?
Yeah.
Part of me thinks I can do this forever. As hard as it is, I still get so much satisfaction from it. I really am comforted by what I can do for other people. And at the same time, part of me thinks I can't do this forever, because the emotional toll that it takes, even if I don't feel it day to day, at some point, the cumulative emotional toll, it may be too much. And so I am always thinking, are there other things I might be able to do that would still bring me that happiness? And I think a lot about perhaps going into the more of the geriatrics primary care field, being able to see people when they're still healthier and well, but then having that continuity with them and still being there for them as they get sicker and when their lives do come to an end, and not just coming in at the end, but actually transitioning with them throughout that whole process.
Yeah.
And maybe something that I do in the future more of.
Yeah. Sign me up for that.
I will.
Okay.
I'll let you know.
Because that, to me, that sounds like my grandmother even went to the same doctor from the beginning to the end.
Yes.
Because there was only one. Beside the point. It's absolutely lovely to, as somebody who is about to enter the geriatric phase of her life, if I had that same doctor who knew me for, say, the 25 years, I can't imagine that care wouldn't be anything except for exactly what I needed.
Yeah. And that is exactly why I decided to do both geriatrics and palliative care, because I love that ability to take care of somebody when they're in their younger years or in their healthier years, and support them through that and be their champion for all sorts of things if the patient wants to do that, but also provide that constant, steady support when or if things change and the patient no longer wants to pursue certain treatments, and to know that they have somebody who already knows them and gets them and supports them and will shepherd them, help them through the next phase of life. It's really an honor to be able to do something like that.
Yeah, well said. I totally agree. I love this conversation. Thank you.
Me too. Thank you for having me.
Yeah, I hope that our listeners have really heard something new today, maybe got a little curious. In the show notes, I'll put some resources on palliative care and a little bio about the good Dr. Balland here. And Laura, thank you. Thank you so much for what you do for people. And thank you so much for what you do for yourself in order for you to continue to do for people. I know that you have such an amazing heart and you're not afraid to show it.
Thank you.
Which is really cool.
Likewise. And I'll extend the gratitude to you as well for doing this podcast, because maybe I should have included that in the future of palliative care. I do think more and more palliative care and hospice providers are going to be getting into the social media sphere, because we need to be able to expand and tell people what we do and have them listen to providers like you and me and know that palliative care and hospice care doesn't have to be this very scary thing. It can actually be full of support and love. So I appreciate what you're doing very much.
Yeah, you're very welcome. Very welcome.
Thank you for joining me as we explored the lives, the jobs, and the stories from the experts who spend their time in the gap. This show and all of our shows are live streamed to your favorite podcast platform.